so type 2 diabetes, and this one is the one we see in the hospital and in the community and in our families, and it's a lot more common and modifiable. There are a lot of things that we can do to make it go away, prevent it from happening. So this is one that we can really have a positive effect on as nurses. So this is one that you really want to know and embrace, and it's going to be everywhere where you work. Okay. All right. So we're going to type 2. Our type 2 diabetic is going to be a woman. Okay.
Wilma.
Wilma. I love it. Okay. Wilma. How old do we think Wilma is?
68.
57.
Sandy's on a roll. 57.
And
Okay.
she weighs 287.
Wow. And she's 5'4".
5'2".
5'1". Oh, she's 5 foot.
5 foot, 287.
287?
Yeah.
Abuela.
Yeah.
Well, she's older, so she's short. Yeah, that makes sense.
Yeah. All right. So
Definitely check her feet.
we've already got risk factors, right?
Yeah.
Okay. Age, BMI. Okay. Let's say that she's Hispanic. Okay. This is Sandy's Wilma. So, she's Hispanic. She could be. These are the non-white. So African American, Asian, Pacific Islander. How many people can I offend? So this lady is Hispanic, and she. What kind of medical history does she have? Anything that
Hypertension.
Hypertension.
Cardiovascular disease.
Okay, so she's
Osteoporosis.
osteoporosis. Increased lipids.
And cholesterol super.
And cholesterol. All right, so this is all good stuff. Well, because she loves Mexican food, as I do, right? And she eats the good stuff, like with the lard and all the, yeah, the good stuff. So
Fried stuff.
that's why her cholesterol's high. Okay, so there we go. She is like a walking billboard for type 2 diabetes, right? And she's had, let's say, 3 kids, and she had gestational diabetes with all of them.
Oh.
Okay, which is also a risk factor. All right. So she goes to the hospital. She's having headache. And she thinks, this is kind of how it felt when I had my high blood pressure for the first time. So she comes in with something completely undiabetes related, right? And you're talking to her, and she says, well, I get up all night long to have to pee. All night. And I try not to drink too much water so I don't have to get up, right? Getting old is terrible. I'm peeing all night long, okay? So frequent urination. And I'm thirsty all the time. I cannot drink enough tea or horchata or whatever she likes. Okay. I'm very thirsty. All the time. Nothing quenches it. Nothing. Okay. And I'm hungry all the time. That's why I'm so fat,
Can't have enough beans.
right?
Yeah.
Okay. All right,
She's
so
not eating a tortilla, that's why.
she's not putting any of this with, this is not something that would bring you to the hospital. I'm thirsty and I pee a lot,
Sounds like me.
right? So,
You're not.
yeah, sounds like we don't pee a lot though usually. Okay, so she's got the classic symptoms, okay? Classic symptoms that you should know. And you should be able to recognize.
Can she have cholesterol deposits in her eye, or what is that?
No, she doesn't have any of that stuff.
Oh.
And so she's diagnosed with diabetes, type 2. Her A1C is 9. And she's got positive ketones and glucose in the urine. Her creatinine is 1 1.9.
What's your
Okay, what does that tell us?
Kidneys.
She's having some kidney issues related to it. So creatinine tells us kidney damage. So this tells us that, we may be developing a problem here. What does the A1C of 9 tell us?
That there's not monitoring or?
It's high. for
Yeah, her
people.
sugar's been high for like the last 3 months.
Yes.
So it's kind of nice, you can't lie anymore. You can't say, oh no, my sugar's always good, because proof is in the pudding, right? We're measuring how much sugar basically is stuck to your cells all the time. Okay, so because this creatinine is elevated, what's one of the things that we really want to know
Her renal
taking care of this lady? Life-threatening complications.
Potassium.
Potassium. Why?
dysrhythmias.
Dysrhythmias, okay.
Because of metabolic acidosis.
It'll cause metabolic acidosis,
So the
okay.
hydrogen ion.
What if her potassium is high? Is it gonna go down?
Yes. When it
Not with that insulin.
shifts
We're gonna have to do something, right? The chances of it going up and up and up are high. So we need to know what the potassium is. So we're gonna say our potassium is 4.5, which is fine, right?
The cocktail?
Okay, so she's now diagnosed with diabetes. Are we noticing any differences yet with type 2 versus, so between Wilma and Fred?
So it's later age, earlier age for type 1.
So she's older.
Her whole entire BMI is like super, super off.
Right, this stuff's modifiable,
Yeah, everything's
Right.
modifiable.
right, except maybe the hypertension, but it can be controlled, right? And the gestational diabetes, you know,
Increases
who
her
knows if she was
chances.
able to control that or not. Sometimes that just happens anyway. So a lot of modifiable stuff. In Fred's case, he's out of luck unless he gets a pancreas, a new pancreas, and we don't, that's not like the routine care, right? Okay, so we're seeing lots of differences. So what is our treatment plan going to be for Wilma? Obviously, it's all that same teaching stuff. So she's gonna need diet teaching, right? So she's gonna have to count her carbs and her proteins and her fats. Thankfully, we live now in a world where there's an app for that. Somebody will have to show Wilma how to do it, but, you know, it'll be nice to control, or easier to control. Accu-checks. How often is she gonna do Accu-checks?
Couple for meals.
And
Hours.
ACNHS, yep. What about her sick day?
Monitor.
Same thing. You
It's the same
monitor it,
thing.
Yeah.
Yeah, sick day rules apply, same sick day rules. So, she needs to check her sugar more frequently, all right? And then, of course, she'll have that scale, that the doctor's gonna write for her and say, this is where we want your sugar, this is the goal, okay? And then the evening snack that will last her through the night, so, you know, not the pint of ice cream that she's been having. Something with some substance, some kind of complex carbs, a little bit of protein, a little bit of fat. And you know, that varies depending on the person. So it may take a few bedtime snacks to figure out, well, with this bedtime snack, I did not do well. My sugar was really low or really high in the morning. Let me try something different, okay? Okay, so what is her treatment gonna be?
Oral.
Yeah, they're gonna start her on oral hypoglycemics. Okay? So metformin, what's the other word for metformin? Because this is the
Guanine?
brand.
Glucophage?
Glucophage.
Something like that. It was a G.
So though the NCLEX is all generic names, who is it that uses brand names?
The NCLEX.
No, the NCLEX uses
The
only
patients.
The hospital.
generic. The patients, the TV commercial. Though they do use generic ones and it's kind of fun to repeat them, most people are not gonna do that, right? So you really have to know both. Okay, so Most of us, the brand name is easier to say. For some reason, oftentimes it's easier to remember. Some of them are actually named so that you can actually kind of work out what they're for, right? So you might learn metformin more, but you have to recognize what the generic name is because that will be the one on the NCLEX. Okay? And most of the exams that we're doing in this program should also be generic names. So you really just have to learn both. Okay, so metformin, what else?
Diet and exercise.
Any other examples of hypoglycemics?
Sulfonylurea.
Sol, is that, I'm not, I think there, isn't there a, I feel like there's a Y in there somewhere.
After the M.
Right here?
Okay.
Sulfonyl.
Sulfonylurea.
We get it.
Let's say it, it's spelled. So what kind of drugs are that? That's a class of drugs, right? What kind of drugs are in there?
There's a Zytes.
A what?
Glipizide.
Glipizide? Okay, so yeah, so they have a similar ending for their generic names, right?
Yeah,
Glyburide. Limepiride. Glyburide. Why do they all start with G?
Thank you.
Make it harder for us.
I'm not sure. I'm not sure if that's spelled right. Some guy named George named all of these. No, I'm just kidding. So they're all gonna start with G. Okay, so they're gonna start her on one type of oral drug, and most of them either help you be less insulin resistant. So you have a cell that has armor on it, right? And so the insulin can't get in, or the sugar can't get in. The insulin is supposed to remove the armor so the sugar can get in the cell, right? Or the key that unlocks it, however you want it. With these drugs, they make the armor maybe a little bit less. So instead of steel armor, it's chainmail. So some of the sugar can kind of sneak in, whatever analogy works for you. So some of them will help you be more susceptible to bringing in the sugar, and some of them will tell your liver to cool it on making the glycogen. Okay, so they do a couple of different things. So depending upon what they do, they may add another one. So if the patient is on one that makes them less resistant, but they still need more, and they increase the dose, and now it's increased enough, like they're not going to increase it anymore, they'll add another one that is going to now work on the liver. Because that's how it usually goes. They start with one that they know works really well, then they increase the dose, same thing with hypertension, and then when they've kind of maxed out that one's usefulness, they'll add another one that kind of attacks the problem from a different way. Okay? Now, these POs are going to be, as with all POs, they are going to be affected by absorption, if the patient is throwing up, if the patient gets an ulcer, if the patient has gastric bypass. Any of those kinds of things can affect how they metabolize this. And once it's in, it's in. You can't take it back. So when they first go on these, you have to really watch them because you've given them something new that could work wonderfully and use up all their sugar, and now their sugar's really, really low. You just don't know how it's going to affect them, right? The metformin is special. This is one that you have to know. What organ does the metformin, is it almost 100% processed? And kidneys. So if the kidneys are damaged, if the kidneys are struggling, meaning the creatinine is elevated, if the patient is going to get contrast, so which is usually a CT scan or the cath lab, then we'll either have to give them a kidney protectant or they've gotta be off their metformin for a week. Most of our patients don't come in and we say, oh, I know you're having chest pain, but we're gonna hold the metformin and give you insulin for a week, which they're gonna love, and then do the heart cath. Yeah, not gonna work that way. So if they go for one of these procedures, and this is a little beyond what you need to know, but I feel like I have to tell you or I'm being irresponsible. So the patient comes, so Wilma comes in, having chest pain, doctor wants to take her to the cath lab, and she's been on metformin. And now her creatinine is 2.1. And, okay, so obviously we're gonna not order the metformin. She's gonna be on Accuchex and insulin. While in the hospital. What's Wilma gonna say about that? We're gonna check her sugar and give her insulin.
She doesn't take insulin.
I'm not on insulin. I'm not that kind of diabetic. I'm not that bad. I just have a touch of diabetes. So psychologically, it kind of messes with you, and I cannot tell you how many patients I have heard that from. They think that now that they're getting insulin, they now have diabetes, and we have just put a label on their forehead, right? Because it does have a negative connotation to some, right? Okay, so she's gonna be on Accuchex and insulin. We're going to give her Mucomist. What's the other name for Mucomist? It's escaping me right now. If you look it up, it's a mucolytic. You're like, well, great, her mucus will be thin. How is that gonna help with kidneys? It is also for Tylenol overdose. It is also used very frequently as a kidney protectant prior to going for a procedure with contrast.
Acetylcysteine.
Acetylcysteine, thank you.
I just
Okay. Mucomist, sometimes they'll give like a bicarb to prevent acidosis, because if the kidneys are struggling, right? Acidosis, metabolic acidosis. So sometimes they'll give them some bicarb. After the procedure, you have to flush those kidneys out, get rid of all that contrast, or it's gonna gum up that water pump that is your kidney, right? So we're gonna force fluids and try to kind of get the pump running and get all that contrast poop out of it. So as a nurse, these are things that you have to think about, okay? So metformin, super important that you guys know about metformin, okay? So what are the things that we have to worry about Wilma? What are the complications that we want to prevent? So, anything with wounds, right? So foot care, she still has to have the foot care talk. Guess what, Wilma, you get to go get a pedicure every week now. I mean, you know, let's look on the positive, right? She's probably gonna like that.
And they're supposed to check it every day, or?
I think it's every week.
It's daily.
I don't remember, does it say daily in the book?
Yeah, because I got it wrong on a question where it said weekly, and then it said no, you have to be checked daily. Yeah.
So, why their feet? Yeah, I step on something, ouch, I'm gonna look at my foot. They get diabetic neuropathy.
Because of the arthrosclerosis.
It has to do with, and I don't have the specific pathophysiology, it has to do with the effect of all of that sugar on the neurons.
Oh yeah, the neurons take a certain type of sugar.
And neurons and nerves and your brain likes sugar. This is why, well, this is part of why I'm feeling kind of down, whatever. I've been reading my book, I'm just not into it. And I go eat a candy bar, and boy, I'm feeling pretty good now. For a little while. My brain is like, sugar, thank you, I'm ready. Okay, so we love sugar. Our brain loves sugar, all of our neural system likes sugar. Okay? But too much sugar, sugar sticks. So if you think about anything related to diabetes complications, think about all that sugar running through people's veins and arteries, right? And the heart is trying to pump. It's hard enough just to pump blood because we all know how thick blood is. And if you don't thin it with an anticoagulant, if you don't manage the blood pressure, whatever, now you're trying to pump maple syrup, pudding, I don't know, something really sticky and that's not supposed to go through plumbing.
Molasses?
Molasses, honey, okay? So that's largely why we have issues. So if you have sticky blood and now you have cholesterol and it's gonna stick to the sticky blood, or you have an injury on the inside and your body is sending out the white cells and all the stuff that you need to make a clot, it's all gonna massively stick to everything along the way. Okay, so, and you think about sugar, like sugar crystals, it's abrasive, right? So it causes damage and it gets stuck in all those tiny little capillaries, and that's why we have such a perfusion problem, and, you know, clogs up your organs and stuff. I'm trying to keep it in real layman's terms, because I know it does all kinds of other things. But just that will help you figure out what the complications are and kind of why they're happening, okay? So anything with wounds, so we have neuropathy, we have numbness. Woman could have an MI and not know it, because she's not feeling it, right? We have to be able to feel the pain. Plus women have atypical chest pain, but that does happen. And then they could also become septic here with this, I don't remember exactly when, but we had a construction guy step on a nail at a construction site and didn't know it for hours. Somebody must have looked at his foot, and he had this nail in his foot, and he had no idea. And so, of course, by the time we see him, it's a problem, right? Sepsis, and he didn't lose his foot, didn't know he had diabetes. It was kind of a whole big can of worms that got opened up. He was actually a very nice gentleman. He was very thankful that he stepped on that nail, because he thought, I would never have known that I had this problem. He wasn't wearing the right shoes. I mean, it was all kinds of things. So they have neuropathy. They can develop kidney failure and go on dialysis. They can go blind or have any other kind of vision issues, you know, along the way. They can lose extremities. Often we see, because of the foot issue and the neuropathy, they lose their toes. They get amputations, you know, and that psychologically is horrible. And mobility then, it can be a problem. All kinds of issues with prosthetics and insurance, and I mean, there's just, the list goes on and on, okay? So lots of complications we're trying to prevent with Wilma. Anything else with type 2? Does she have to have any of these things? No. No, what does Wilma have to do to stay healthy?
Lose weight and exercise and change your life.
Yeah, she's gotta keep her sugar managed. If you manage your sugar, then you're like everybody else, right? It's just that your pancreas doesn't behave, or your cells are just antisocial, right? And instead of it being a natural process, you have to do something from the outside. But if they're managing their sugar, my sugar of 110 is the same as Wilma's sugar of 110. We both have a sugar of 110. She had to take a pill this morning, and she had to go for a walk. I didn't have to do anything, but we both have a sugar of 110. It's the same. Okay, so people with diabetes need to understand that. There is no reason you need to have any problems. It gets a little tricky on sick day, you know, but that's what we're here there for, is to educate them. And she needs to lose weight, and she probably needs to be part of a support group. It's not going to work if her family is having that awesome you know, taco bar every Friday, family's gonna have to support her, which could be a problem, unless she's the one that's running the taco bar, right? I love tacos. Okay, so that is type 2 diabetes.